Next slide. Yeah, so the University of Alberta respectfully acknowledges that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. We appreciate that you've joined us today to hear our expert guest speaker, Dr. Matt Keeling, and he's going to talk on COVID-19 in the UK, data, models, projection, and policy, along with Professor Lisa Phillips and Dr. Teresa Tam, who've joined us to give opening remarks. This is the second lecture of our Distinguished Lecture Series of 2022. It's timely for our network and researchers in this field because we aim to establish the relevance and importance of various fields and disciplines working together. It's very interdisciplinary work, and it focuses on modeling emerging infectious diseases, and in particular focuses on the One Health perspective. Throughout the year, our network OMNI will continue to invite experts to share their research with us from the lens and expertise of public health, also wild and domestic animal health, the environment, and the One Health approach, bringing these things together and focusing on research problems and data collection and the sources and the challenges and the relevance of their field to modeling. Next slide, please. Before we dive into the presentation, I'd like to take the opportunity to introduce my fellow co-directors of OMNI-RÉUNIS. Dr. Haiping Zhu is at York University. He's the lead, and Dr. Hélène Carabin at the University of Montreal is a co-director. We're leading the network to bring a range of expertise in research, mathematical modeling, and biology, and veterinary science to bear on the questions. Furthermore, York University has been a key supporter of this network, hosting us through the Canadian Centre for Disease Modeling, CCDM, and we thank them for their generous support in helping us establish an OMNI research lab for our residents and visiting researchers. With that, I'm delighted to welcome our special guest, who will be giving us opening remarks, Provost and Vice President Academic of York University, Professor Lisa Phillips. Professor Phillips has provided outstanding leadership in her esteemed role since 2017, and she's led many impactful institutional initiatives. This includes collaborating with academic policy and planning and research of the Senate to craft a university academic plan. Beyond York University, she's provided legal advice to a range of bodies, including the Ontario Ministry of Finance, the Special Counsel in 2015. She also served as interim dean in 2015-16 of the Boer-Alaskan Faculty of Law at Lakehead, which was a new law school, with a mandate to strengthen the Indigenous bar and prepare lawyers to practice in northern and rural communities. So welcome, Lisa Phillips.
Thank you so much, Dr. Lewis, and it's a great honor for me to have a chance to speak to you for just a couple of minutes. I want to warmly welcome Dr. Tam and Dr. Keeling. Thank you so much for being with us today, and to all of you who've come together to pursue this absolutely critical work. This lecture today brings to mind for me just how much we've been through over the last 2 years of the pandemic, and how much we have relied on the kind of data and public health knowledge that scientists like all of you have helped to bring forward, working together in unprecedented ways to really keep up with a world of constant change, and to try to help the world really prepare as best we can to mitigate some of the effects. So I think that it's poignant for me to note that in the fall of 2021, just a few months ago, we were able to start welcoming back thousands of students to our campuses. That increased and intensified over the winter term once we got a little bit past the Omicron wave, the worst of it. And this has been so meaningful and important to the lives of so many of those students and their families, their futures, their well-being, their ability to contribute in future to making Canada a better place in the world, a healthier, better place. This has been a time of such immense uncertainty, which I think has been deeply challenging for many individuals. But we have successfully navigated our way through in many ways. And it is precisely because of the hard work of our scientists, both in academia and in the public sector, researchers who have been able to inform our policymakers and call upon them to act in ways that are based on evidence to resist some of the political pressures and panic reactions that are very normal and expected in such a time, but which have to be, we have to try to conquer with rational thought, with the analysis of the data and the scientific knowledge that we know it really should be predominating. So at York University, we're extremely fortunate and proud to have some of this top expertise right amongst our ranks, including Dr. Weiping Zhu, who leads this One Health Modeling Network. It's very impressive that NSERC and the Public Health Agency of Canada invested $2.5 million to enable this network to keep coming together and to enhance its work. That is tremendous. We're also very fortunate, of course, to have Dr. Jianhong Wu, Dr. Jane Heffernan, many others who have contributed to this work and who are widely recognized as leading experts in the field. And we are very proud also that not only are they top scientists, but that they are contributing so actively to public knowledge creation and mobilization and network building to strengthen Canada's response. Indeed, this pandemic has taught us a lot about global cooperation in knowledge sharing and the importance of looking beyond our own borders. I'm always struck by how difficult it remains to keep remembering that lesson, that what's happening in the rest of the world matters deeply to what's happening in Canada, what's going to happen in Canada, and vice versa. And so I'm thrilled to have Dr. Keeling with us here today to talk about UK lessons learned and experiences. Certainly, this has been one of the jurisdictions we have looked to understand what's going on, but also to gain knowledge and expertise from. And so this is very, very consistent with our longstanding values at York University of reaching across national borders, of looking strongly to address equity issues and social justice issues with our research and our teaching, and to be as collaborative as we possibly can in including others in this work. And so thank you to everyone for joining us today. I will stop there and look forward very much to hearing from all of you. Thank you.
Thank you very much for your remarks, Professor Phillips. I would like to introduce another special guest to give an opening address, Canada's Chief Public Health Officer, Dr. Theresa Tam. And we've all got to know Dr. Tam as a fierce public health advocate and a key voice in guiding Canadians during our COVID-19 pandemic. And you just have to turn on the evening news to see that. In 2017, or since 2017, she's held the esteemed position of Chief Public Health Officer of Canada. She's a pediatric infectious disease specialist with expertise in immunization, emergency preparedness, and global health security, and is a graduate of the Canadian Field Epidemiology Program. She's also a fellow of the Royal College of Physicians and Surgeons of Canada and has over 55 peer-reviewed journal publications in public health. During her 25 years in public health, where she held several senior leadership positions, they've been at the Public Health Agency of Canada, including Deputy Chief Public Health Officer and Assistant Deputy Minister for Infectious Disease Prevention and Control. She's provided technical expertise and leadership on new initiatives to improve communicable disease surveillance, enhance immunization programs, and strengthen health emergency management and laboratory biosafety and biosecurity, all these things that are so crucial to our quality of life as a nation. She's played a leadership role in Canada's response to public health emergencies, not only in COVID-19, but in SARS, pandemic influenza, and Ebola. And she's served internationally on a number of World Health Organizations and committees, and has participated in multiple international missions related to SARS pandemic and also polio eradication. So Dr. Theresa Tam, I invite you to talk to us.
Thank you so much, Dr. Lewis, and thank you, Professor Phillips. I'm so happy to be here today. Bonjour à toutes et à tous. Je suis à Ottawa et j'aimerais souligner que je m'adresse à vous depuis le territoire traditionnel non cédé du peuple algonquin Anishinaabe. I'm joining you today from the traditional and ceded territory of the Algonquin Anishinaabe people. Thank you so much, OMNI-RÉUNIS and other experts of the Canadian infectious disease modeling community for your collaboration with the Public Health Agency of Canada's modelers in our collective efforts during the COVID-19 pandemic. And it's great to have international speakers. It's been very valuable from my perspective to link with colleagues in the UK, including their modeling expertise as well. So mathematical models that helps us estimate the potential impact of the pandemic, forecasted the trajectory of the pandemic, and estimated the effects of interventions such as vaccines and some of the public health measures aimed at reducing contacts have really informed the Public Health Agency's work, our government decisions on the management of the pandemic. As the Chief Public Health Officer, I think I'm an end user of your work. I've been utilizing the work of modelers, including in my press conferences that you've just mentioned, to complement the epidemiological updates. And I think the public and the media have appreciated these kind of presentations. At the Public Health Agency, of course, we work across Canada with the provinces and territories to obtain valid data, including epidemiological estimates from across the country on an ongoing basis to inform the development of accurate and useful models. And these models, as they are refined over time, helped us to understand the disease dynamics, which allowed us to calibrate our response, and at the moment enhancing our preparedness as new SARS-CoV-2 variants with maybe different characteristics continue to emerge. I think many of you have seen that the wastewater surveillance capacity has expanded across the country, and the data generated right now is being used to inform our wastewater epidemic model. I think in public health, we recognize the interconnectedness of human, animal, and environmental health and the importance of a One Health approach to assessing the risk of emerging infectious diseases and other things like antimicrobial resistance, and so that we can design and implement prevention and control methods. So it's great to have multi-sectoral modeling networks that include scientists for different disciplines, universities, public health, government, indeed communities that are poised to move from knowledge generation to policy and practice to help tackle complex health challenges, indeed, as we are trying to adapt to climate change. So I look forward to future collaborations. Thank you very much. Merci. Megwidge.
Thank you very much for your address, Dr. Tam. We're so pleased to have both of you here today. We're pleased to have Dr. Matt Keeling here with us all the way from the UK to present his research on COVID-19 in the UK, data, models, projections, and policy. Dr. Keeling is a professor of mathematics in the Mathematical Institute and School of Life Sciences at the University of Warwick, and he's director of the Zeeman Institute and deputy director of mathematics for Real World Systems Center for Doctoral Training. He's received many recognitions for his work. These include being recently appointed to the Officer of the Order of the British Empire in 2021 for the services rendered during the COVID-19 response. His research focuses on what sort of the OMNI-RÉUNIS network is all about, connections between epidemiology, evolution, and ecology. And he's particularly interested in how spatial structure, heterogeneities, and stochasticities affect emergent population level dynamics. And he's working on the optimal control of infection, cost-effective vaccination policy, and things like vector host dynamics and within host immunological dynamics of disease. And so let's dive into the lecture without further ado. I would kindly ask you to turn off your microphones during the lecture, and afterwards we'll have a question and answer session, and you'll be able to ask questions and type them into the chat. So welcome, Matt, and take it away.
Hi, so hopefully you can all see my screen. It's an absolute pleasure to be here, and thank you ever so much for the invite. I ought to say, I mean, Mark's just said that I'm known for stochastic models and spatial models. In fact, most of this is not stochastic and not spatial. But what I want to talk about is the work that we've done in the UK, really thinking about sort of COVID-19 in terms of policy and data. So this is very much a personal perspective. It's also very much a UK perspective. So we are involved with a team in Kenya that's been looking at the outbreak over there. But this is very much focused on the UK. It's also a personal perspective. So I'm a mathematician by training, but I've gradually been pulled more and more into thinking about science for policy and really about how we can use mathematics in a sensible way to address important questions. It's also the story of building up from relatively simple models to incredibly complicated ones. I never want to make a model this complicated ever again. But it's also about how that's driven by demands of policy and also new pieces of data that start arising. So I'm going to focus on four main areas. I'm going to dip chronologically into other things that happened sort of as we were going through the pandemic. I'll talk about early days of control. I'll talk a lot about vaccination. I'll then do quite a long section about roadmaps, which really was about how the UK moved out of lockdown all the way to full relaxation. And then finally, I'll talk a little bit about the complications that have come since then in terms of waning boostings and the Omicron variant, and finish up with a few lessons learned. So to start off with, there's a huge team of people that I need to thank that have done an awful lot of work as part of this. So this is the sort of the Warwick team, and there's also 3 people who we've been working with closely in Kilifi, Kenya. So there's been a large sort of influx of knowledge and transfer of knowledge between different groups. I'd really like to thank Ed Hill and Sam Moore, especially, who are 2 postdocs who have done outstanding work during this pandemic, and a lot of what you see is going to be sort of related to their work. I'd also like to thank Emma, Alex and Glenn, who as PhD students have taken a lot of time out to do some of the really, really boring data sorting that is essential in all these things, but is something that needs doing. So, you know, a big thank you to a lot of people that have been involved. So that's the team at Warwick. I'm fortunate enough that we're also part of lots of other teams. So I'm going to do all my thank yous at the beginning, save them getting drowned out at the end. I'm part of something called the Juniper Consortium, which is across 7 different universities in the UK, all of us pulling together to try and answer questions on COVID. And I won't name everyone here, but it just spans sort of the strength and breadth of UK modelling. I'd also like to thank people in SPIMO, which is the group that's really been pulling together all the model forecasts that then go to our scientific advisory group for the UK, so SAGE, which then follows on and goes to policy. So these are the 3 people that really shield us from the politicians and mean that we can start concentrating on the science and concentrate on the questions rather than worrying about what the politicians are asking us. And the work's also funded by the Medical Research Council and UK Research and Innovation, UKRI. So we've had an awful lot of backing and an awful lot of support, and that's really made this all possible. So, as I said, this is going to be a UK perspective. For a lot of it, it's going to be a very England perspective. So in the usual way of things in the UK, each of the devolved nations, so England, Wales, Scotland and Northern Ireland, all have their own ways of collecting, storing and sending us the data. So there's slight little inconsistencies. So for a large part, it's easier just to focus on the data from England, which is sort of the largest nation. So what we're seeing here is the timescale of the pandemic so far in England. The top graph is looking at positive and negative tests, so negative in green. So every time someone does a test and it comes back negative, we know about it. And every time someone has a positive test, we also know about it. So there's lots and lots of rich information here. Early on in the pandemic, there wasn't much testing going on. So we sort of were in a little bit of a blind spot there. And then as we've moved into the latter stages of the outbreak, free testing has been halted. So we're really not getting as much testing as we were. And then in the very last part, we really aren't getting any negative results either, because the data is just getting too messy. So we have one stream there that's been incredibly useful. The other two streams that we're always going to be looking at are hospital admissions and daily deaths. So these are two of the sort of key observables that we want to be able to model. And just thinking about them in hospital admissions, I've got sort of the different variants that came in that have really driven a series of larger and smaller waves as time's gone on. The other thing to note is that as we've moved through, deaths has become a smaller fraction of hospitalizations, and really that's due to some of the outstanding work that's been done with new drugs and new treatments as we've moved through. So, you know, huge shout out to some of the medics that have done, enabled some of this fantastic work. So when we first started doing this, so I started looking at this like most modelers sort of back in sort of February, March of 2020. It feels like a lifetime ago, but I know it isn't. But lots of our work was hugely speculative. We were making very strong assumptions about all the different transmission mechanisms that could go on. We'd got a very limited understanding, but things that we were clear about early on was that age structure was going to be very important. We knew that younger infections were generally asymptomatic. We also thought they were probably going to be associated with much lower transmission. And what this means is we could take the work of people like Prem, who've sort of tried to project what the interactions would be between age groups based on a large number of socioeconomic data, and try and use that information to project what R0 might look like across the different countries. There's a lot of problems with this. I mean, this was very, very early work, but it's interesting that, you know, some of the things that we were really skeptical of early on, the fact that Africa has got a relatively low R0, so disease wasn't going to spread quite as much, seems to have been borne out. Although, you know, other areas we were predicting India was quite low, and yet India's actually seen a large number of cases. So take these things with a pinch of salt, but I think we were moving in the right direction very, very early on with models. And this was sort of published in April. So, you know, it was quite early into the pandemic when we really didn't understand that much. So throughout this, I'm going to talk about how models and policy interact, and also sort of how data feeds in. So the first thing that came up was that, you know, as a policy, we got sort of lockdowns and household isolation. So we really required a mathematical model that could capture this idea. Now, if we take a simple model where our force of infection, lambda, our risk of individuals being infected, is just related to sort of beta of external interactions and a beta of within household interactions times I, then as we reduce how much external interaction there is, as we put more of a lockdown in, well, yes, things decrease, but if there's enough household transmission, we can still get a positive growth rate. So we know that's not true. We know there's sort of isolation within a household, and we didn't want to go to the full expanse of making a complete household model. So we put in a sort of a fairly simple fix in which we thought about first infections and second infections or subsequent infections within a household. And that leads us to a situation where, as we reduce external infection, we can get better and better control of the epidemic. So at least it's capturing that one element of the policy that we were interested in. The other elements of policy that we had to think about was about the type of data we got. And I said this was mainly hospitals and deaths, so hospital admissions and deaths. We've also got some data on people in ICU. But what this meant was that we needed a model that could capture the timeframe dynamics of infection. We wanted it to be able to capture symptomatic and asymptomatic individuals. And we then wanted it to be able to capture the level of severe outcomes that we were seeing. So we needed this is a relatively simple structured model. We're keeping with the idea of first and subsequent infection. So there's a sort of an extra layer to this. And a lot of this is building up in layers. But essentially, this is a slightly modified version of an SEIR model. So it's nothing sort of outstandingly complicated, but it allows us to capture a lot of the dynamics that we're seeing. The other element that we have to put in is that we know we require age structure. So all our models are partitioned into different age groups. So we run with 21 age groups, so we're using 5-year age bins. We're also, in all of this, we've also modeled this within 7 different regions in England and also the other devolved nations. So we've really got a model that has 10 different replicates of this going on in parallel. So a lot of this, each of the individual components is relatively simple, but by the time you slot them all together, we have systems. My set of ODEs is now several thousand that I run on a regular basis. None of it's particularly complicated. It's just lots and lots of replicates of the same thing with different ages, different regions, and all the other components that are going to come in. So this was all work done in the very early stages of the pandemic. This was April, May time. We were in a lockdown within the UK, so we got sort of isolation. People were only allowed out for essential shops. You could go out and exercise once a day. And really, we're in a very strong containment phase and mitigation. And our main concern even back then was thinking about how we were going to relax from this lockdown. And we started thinking about sort of what levels of control there were going to be in the latter half of 2020. We knew we couldn't stay in lockdown forever. So we assumed there was going to be a gradual releasing or a relaxation of some of the controls. And then we'd assumed that by 2021, I mean, we've got to be sort of over it. And we couldn't have any controls in 2021. And so we looked at this where we thought about what happens as we change the levels of controls in the latter half of 2020 and what impact does that have on 2021. And it won't surprise people, but what we need is a moderate degree. We found a moderate degree of control in 2020, minimize the total epidemic size. So we get a moderately sized epidemic in 2020, and then a moderately sized epidemic in 2021 when we relaxed. But we were still predicting sort of 150,000 deaths. That actually is not too far off where the UK is sitting at the moment. We're sitting at about 160,000 deaths. But before we get too smug and go, oh, we got the numbers right really early on, this was before we got vaccination. This was before we'd seen other variants. So, and it's before we got a lot of the mitigation measures against some of the more severe outcomes. So yes, we were in the ballpark, but we shouldn't go over congratulating ourselves in that respect. So, but at least what it showed was that it was going to be hard, it was going to be complicated to get out of lockdown. And I think that's one of the main messages that you're going to see throughout this talk. So the next thing that sort of really we were all madly modeling throughout all of this, but one of the next major sort of things that happened was we could see that cases were going up from sort of September time in 2020. And so a policy was enacted. And again, this was where policy was driving the models to some extent of local control levels. So each region of the country, each small little local LTLA, so they're local tier local authorities. So they're sort of a very small scale, about 10,000 people in each one. Had a level of control applied, and these were 4 different tiers from 1 to 3, and eventually we had 4 in place later on. And the question was this working? Well, actually, we didn't need very complicated models to this. We've got data on what the local scale dynamics was, and we could just think about intuitive ways of plotting this to visualize what was happening. And what we did was simply plot what was the growth before you put tiers in and what was the growth afterwards. And what you can see is in all of these, as we do tier 1, tier 2, and tier 3 is the strongest, there's a downward shift. So most of the points low below the diagonal. So things get better. We get more control as you put tiers in. But actually, we really want to be down in this bit. We want negative growth rates. We want things to be declining. And you only get that in the strongest measure of tiers. And this is where it was great to have the people in SPI-M sort of working with us, because my first graph was this one, which is just like, let's put it all together in one graph. And it was, my God, you can't show that to everybody. No one's going to understand it. So, great to think about how you break that down, how you start communicating this sort of information out. But also it shows that sometimes you don't need things that are very complicated. simple messages will do. So the next sort of real problem, and this didn't so much come from policy, but really came from us all being very, very concerned that the cases were increasing from sort of August, September onwards. And so one of the ideas that was proposed sort of within the scientific sort of community, more or less, was thinking about circuit breaks, so short-term lockdowns or restrictions to try and halt the growth of cases. The idea was that if we could do this for a short time, 2-3 weeks, it wouldn't place undue strain on the economy. We also thought about maybe we could align this with school half terms so you don't place extra burden on education. Actually, we did, again, very, very simple models, just thinking about what happens as you switch between something that's exponentially growing to an exponentially decaying phase when you put the controls in, and then let it go again to exponentially growing. And what we see is, if you look at this on a log scale, where it's easier because everything's a straight line, we see that these exponentially decaying phases almost just take you back in time. They take you to an earlier point in the outbreak, give you more time to think about how to react. So they're not an absolute strategy. They're never going to stop an ongoing wave, but they are going to tell you, they are going to give you a little bit more time to try and get other mitigation measures in place. Oh, okay, that's what I was going to say. It's stepping back in time. So we did this, obviously, you know, you can do this with a simple model, but what people really want to see is, does this actually happen in the full age structured model with all the bells and whistles on? Not surprisingly, yes, there's a little bit more time between moving from exponential growing to exponential decay, but we can certainly start thinking about what happens as you put it in, depending on what the growth rate is and depending on what the decay rate is. It's also clear that, as I said, these are only a temporary measure, but they do put a very strong delay on this exponential phase and give us time to react, especially as we got the idea that vaccines were coming, and they can also reduce the scale of any overshoot in terms of sort of mitigating, squashing the highest peaks of any outbreak, which again is a good policy in terms of public health. So eventually, the break did come in. It came in November. By then, we were at very large numbers of cases, very large number of hospitalizations. And so what actually has happened was there was a 4-week break put in. It's often said this break didn't do anything, but I think if you look at the data, it's really clear that after the 4-week break, so there's delays in this system between sort of infection and hospitalization, but after this 4-week break, the number of hospitalizations declined dramatically in England. The only one place that doesn't really see that is the Southeast, and which is the pale blue line in here, which you might just about be able to pick up. I mean, it slows, but it doesn't really reverse. And we think that's due to some of the early increases in the Alpha variant that we were seeing at the time. Which brings me on to think about vaccines, which was really our next big thing that we had to start working on. And we knew that vaccines were coming. This was work done in sort of October, so before any of the clinical trials were completed. So we got this idea that, yeah, we knew they were coming. We didn't quite know how good they were. But what that means is we take this already complicated high-dimensional system and effectively double it or even triple it for people who've had 1 or 2 vaccines. And we have to do this because we know risk of symptoms and hospitalization and severe outcomes all depends on your vaccinated state. So we need to keep track of whether you've come from being completely susceptible and naive or whether you've come from being in one of the vaccinated classes to know your risk of ending up as hospitalized. So when we did this initial work, we sort of vaccines as we basically labeled them as 3 types because we still didn't know how they were going to work. Our ideal vaccine was a sort of type 1, which reduces susceptibility to infection and therefore completely blocks transmission or partially blocks transmission to some extent. We've got type 2, which was reducing disease. This had reduced transmission slightly because more people would be asymptomatic and therefore there'd be less transmission going on. But the main impact there would be to stop sort of symptoms and to stop disease. And then the third one just reduced severe disease, but didn't have any impact on transmission. So you'd have the same epidemic roll through, but you wouldn't have as many people getting severely ill. And when we looked at these, we assumed, we hoped we might get 70% efficacy with 2 doses. And we could think about what happened, as you vaccinated more individuals, and what happens as you think about different orders of vaccinating. So here, the blue line is just to randomly give out your vaccination to the entire population. The orange line is doing it in age order, and then the purple line is adding in comorbidities. So if, you know, for all of these, it seems the best strategy is to do the oldest first, then those with comorbidities, and then switch back and do ages. And that really is what happened within the UK vaccination policy. So once we started getting data, and this really isn't until we knew an awful lot more and we could think about what the actual vaccine was doing. It depends slightly on which vaccine we're talking about. So we've had 3 main vaccines, but at the time we'd only got 2. We'd only got the AstraZeneca vaccine and the Pfizer vaccine, and later we got Moderna. But we were looking at transmission blocking in the sort of 65 to 80% regime. So that's better than we were thinking, really, and that depends on the vaccine type. Reducing symptoms is probably 80 to 90%, and reducing severe disease is well over 90% for the original sort of wild type and alpha variants. So where were we? We were somewhere in between types 1 and 2, but probably performing much better than we thought. So, you know, vaccines have just been amazing throughout this pandemic, and, you know, I'm in awe of the people who actually developed them. So we did a lot of this early work on vaccines, and then the next thing that really hit us were variants. So I've already mentioned the sort of alpha variant to some extent, and we'd got early signals in sort of November time that something was happening down in the southeast of England. This is a plot. So these are all the LTLAs, these tiny little units that we've got most of our data at. And what we can see is this is the time to reach 10% of the alpha variant, and it starts in the southeast in early October, spreads generally through the country, moving northwards, and finishes sort of, you know, most places have got it by the end of January. It's not a pure wave, so the very north of England got hit quite early on as well. So it's almost 2 wave fronts coming against each other. What's important and what's useful with the alpha variant was that one of the parts of the PCR testing that gets done in the UK, which is called TACPath, looks for the S gene, and it looks for a particular part of the S gene. And what we find is that for the alpha variant, that's missing. It can't pick it up. So we get S gene failure. And this was used together with genomic confirmation for, we don't genotype all of the different types. And that really told us about the spread of this new variant. So initially, a lot of the work was statistical. So, you know, example of the map there, thinking about what's happening. But at some point, this needed to be added to the model. And that's why I've got these little Christmas decorations all the way around, because, yeah, most people have turkey at Christmas. I seem to spend most Christmases dealing with the new variant. But, you know, it's something that had to be done. So we put in this new variant, this alpha. At the time, it was B117. And we estimated it was about 50% more transmissible than wild type. So in a sneak sort of preview, jumping forwards to some extent, the last year has seen another 3 of these variants of concern. Each one has had a higher transmission rate, as we can infer from the model. So each one's better at reproducing, better at spreading through the population. And amazingly, and I don't know if there's a biological reason behind this, and no one's ever really been able to tell me, each one of them has changed their status of S gene. So when alpha came in, we knew it was there because the S gene didn't pick up. And then as soon as Delta came in, we started picking up S genes again. So we suddenly had a new measure that told us about whether or not this thing was in place. And then BA1 came in, that was S gene, it was an S gene failure, and BA2 was S gene positive. So we flip-flopped between the two, which has given us actually fantastic data. But I don't know whether there's a biological reason behind this flipping between the different states. So the final thing we sort of really started thinking about in early 2020, once we knew we'd got the vaccine in and once we'd got the alpha variant more completely within our model, the policy seemed to be, we've got vaccines, we can just relax. We don't need to do anything there, we can just vaccinate everyone, we'll be okay. We had to sort of very strongly push back against this. And this was some of our early work thinking about it. And what this shows is that even 3 or 4 months after we got vaccines, even when we got to about 30 million doses, so that's an incredible push out of the vaccine, if we suddenly halted all the control measures, so we'd had to put restrictions back in place in early January, but we knew if we suddenly halted them all, we'd get a massive resurgence of disease. I mean, epidemics are very, very prone to these sort of shocks. If you have a sudden change, you're going to get a sudden increase, a sudden exponential growth in cases, and therefore a large wave. So we got this idea already that what we needed to do was relax these MPIs slowly. We still didn't know this was early January, and we still didn't know the impact of the different vaccines. We didn't know how good they'd be at infection blocking. But we could at least start to think about what these outbreaks would look like as we moved between different strategies. But what was clear was that anything that added in, that allowed our MPIs to relax slowly would suppress the future waves. And this really was sort of set the tone for what happened throughout the rest of 2021. So the last bit I just want to say quickly on the vaccines is one of the other questions we were asked, and this really did come down as a sort of a key question from policy, was, you know, if we've got sort of doses of vaccine, do we prioritize giving people 2 doses, or do we prioritize getting more first doses into the population? And Professor Van Tam, who was sort of one of the great spokespeople of public health, sort of said, yeah, he epitomized this as, if you've got 2 doses of vaccine, do you give them both to your granny, or do you give one to your granny and one to your granddad? And actually, it's a really interesting question. When you start working through and think about how effective the doses are, it really depends on how good your first dose is relative to your second one. And so we could come out with timelines of when do you do first dose and when do you do second dose. And if the first dose only gives you 70% of the protection of the second dose, then you want to start bringing in that second dose more and more quickly. In particular, you really want to focus on care home workers and residents in those very early stages. But if your first dose does a lot of the protection, here we've got 90%, you can delay things much more and really focus on getting lots and lots of first doses into the population. So your first sort of 11 million doses here would all be first doses into people and give some level of protection to those most vulnerable individuals. So the last thing I sort of want to focus on is the roadmap that we did, which is really following on from this idea that we couldn't just relax all of a sudden. We couldn't just switch off all our controls. And so there was a series, there was 6 roadmaps eventually. I'll mainly talk about the first ones. And really it was about, what do we do? How many steps do we need to come out of this? And over what sort of time scale? So this was sort of work done. We started doing it in sort of February time. So here the blue dots are the information we had up till then, and the orange dots are what we actually got going forwards. And we thought about strategies here that this was sort of given to us by policymakers, which was, we could do a complete relaxation by early May, so i.e., 3 months and we've scrapped all restrictions, all the way to something that's much slower, in which we don't get complete relaxation until August, which is this sort of yellow dashed line. And the actual policy that was chosen was somewhere between the orange and the yellow. And in which case you can say, well, our models didn't do too bad, other than the fact that we've had new variants since then. So, yes, they gave us a good flavor of what was going on, but there's still details that we need to think about more. So as we moved through, we got a set of these roadmaps. We ended up doing one every 5 weeks to think about whether or not we were okay for the next step going forwards. So roadmap 2 was looking at steps 2 to 4. So 2 was sort of opening non-essential shops. I think 3 was basically opening pubs and restaurants, and then 4 was a complete scrapping of all the social distance measures. What did we get? Well, the problem was we didn't really know what these steps would look like in terms of population. We were estimating it based on what controls had been in before and what was the level of mixing that had generated. And so we were getting slight amounts of information. But certainly in the very early days, we'd overestimated the amount of mixing that was going to go on once we moved through these relaxations. We'd underestimated vaccine efficacy quite considerably. So the early estimates that we got through, so that was really done by Public Health England, but the early estimates of vaccine efficacy were quite low. And of course, we didn't know about Delta. So here we're looking at the impact of different seasonalities that we did. And we're actually now using 10% seasonality, which seems to fit with some of the data that's out there. So that's now our default. Now, our blue line's not looking too bad compared to what was actually seen, certainly up until the first peak in August, and then things start to go a bit awry. Roadmaps 3, really, really difficult. We'd only had two steps. We'd had one which was just putting schools back. 2 really wasn't a drastic change, and we hadn't got enough data yet to start to see the impact of that, because it had only happened sort of 2 or 3 weeks beforehand. And so we were estimating from a very, very low number of cases, which is always hard because you're trying to see up this exponentially increasing sort of hill and try and projecting where it was. So we underestimated what was going to happen over the next few months, and particularly that might have been because we just didn't know that the Delta variant was around the corner. When we moved to roadmap 4, we knew that Delta was in. We'd have been in for about a month in the UK, but we still hadn't got large numbers of cases of Delta. We were at a bit of a low. The biggest problem was that we didn't know how the vaccine was going to protect against the Delta variant. And so we've got lots of different assumptions on this. We've got a sort of what we called a cautious assumption, which was actually, this is your safest bet. And then we've got this optimistic assumption, which was much closer to reality. And what this meant was that there was huge uncertainty about what was going to happen in step 4. And this actually led to a delay of about 4 to 5 weeks. So actually, what actually happened was we sat on this orange curve. So we delayed this step 4 for longer before it became introduced. But again, we were on all of those, we were always measuring, we were always modeling each step. Step 3 is open the pubs. Our assumption was everyone was going to go down the pub that night. Actually, by the time we were doing roadmap 4B, we'd really realized that wasn't the case. We knew that what was happening was that people were actually quite slow to responding. We don't think we're nowhere near back to normal even now. And so we got this idea that the relaxation was a much slower process, although we couldn't say how slow. So we ended up doing lots of different speeds of relaxation, which gave us a massive envelope of what could happen, some of which have this sort of slow oscillatory type behavior that we've actually seen in our data for the Delta wave. But there are some things that we failed to get. For example, we failed to predict how quickly the epidemic was going to rise due to people celebrating the football. And, we get criticized for this, but I'm sorry, predicting football is beyond what we can put into our epidemic models. So thinking more up to date, what's been happening more recently? Well, the most recent thing that's really happened is thinking about Omicron. So Omicron sort of hit the UK at really at the end of November. And by the middle of December, we were asked to make some quite detailed policy forecasts to think about what was going to happen. We also knew then that the vaccine wasn't lifelong. It was waning, and it was waning over quite a rapid sort of timescale. And the waning was also much faster for Omicron than we were seeing for Delta. So we had to start bringing in lots and lots of extra components into the model. So we'd gone from having a sort of S, V1, V2 for 2 different stages of vaccine. We had to think about multiple stages of waning. We had to start thinking about waning from individuals who'd already recovered. So we now know that Omicron, we've seen lots of reinfection. And then we've got a booster that came in, and we were either thinking the booster is going to give people permanent immunity, or we're going to see repeated patterns of waning, and repeated patterns of waning is probably what we've seen up until now. So suddenly our model has lots more classes and lots more arrows to make things much more complicated. So we did this modeling. So this was all done sort of in early December, and again, it was fantastic to have this huge team around us sort of helping with things, pulling together the data. And there was lots of uncertainty in this. So we did think that there might be a sort of policy reaction. We thought there might be another lockdown or another form of control. So we measured different strengths of control. We also measured different severities. We knew Omicron from South African data was likely to be less severe. So we looked at different relaxation. We looked at different levels of severity. But actually, there wasn't any policy change. So we didn't put any MPIs in. And so really, we should be off the top of this graph. We should be having sort of, very, very large outbreaks. But actually, Chris Whitty, our CMO, our Chief Medical Officer, basically made a plea to the nation of, if you want to save Christmas, restrain behavior, mass testing, make sure you take a lateral flow test before you go and visit your family. And actually, this had a huge impact on people's behavior. It really sort of knocked back the amount of sort of social mixing that was going on as people really prioritized seeing family over the Christmas period. And I mean, this is just one of the graphs, and it's zoomed in from what we were actually presenting. But what we found was that this plea acted as a brake on human behavior. And it was probably as good, if not better, than any lockdown. And so if instead of thinking of these as an imposed increase in MPIs, we really thought of them as a voluntary increase in MPIs, then actually they get quite a good match for what we saw at the time. So the purple line is one set of sort of MPIs over a given time frame. So I'd just like to finish this off, and I've got a couple of minutes to talk about lessons learned in all of this. One of the things that I've learned over this pandemic is you have to develop a very thick skin. Models are projections of what might happen, and therefore when you put them out there, it means people can compare them to the unfolding epidemic. They're going to be scrutinized in a lot of detail. They're going to come in for an awful lot of criticism. But what I've sort of found is that if you're getting criticized equally by both sides, so, we get criticized for not vaccinating kids soon enough, but also vaccinating kids too soon, then you're probably doing the right sort of thing. I've also learned you really can't predict human behavior. The football, well, we couldn't predict how long that was going to go on for. There was then something called the pingdemic, which really was a reaction to the number of cases that were going up, and the amount of mobile phone tracing apps that were then picking up infection just went ballistic, and suddenly we got this massive downturn in cases. I don't think we could have predicted that. We also couldn't respond. We couldn't predict how well people were going to respond to Chris Whitty's plea. But all in all, these things are just part of the uncertainty. Models are always going to be wrong, but we hope that in general they're useful. And quite often the departure of future data from what we've projected can often hint at underlying changes in behavior and things that are important. Data is key throughout all of this. Models are nothing without data, and a real plea to think about all the different sources. There was a comment at the beginning about wastewater. One of the sources that we haven't really used as much as I think we could have done throughout some of the modeling. We also haven't used genetic data as much as I'd have liked to have done. And I think some of that is just how the timescale of this outbreak compared to the timescale it takes to get the genetic data. The media is always going to focus on worst case scenarios. Every time you put something out, they will look at the top of the graph and see how big it gets. And then you'll get criticized when that isn't actually what unfolds. I think it's really good if we can bring in a holistic approach on all this. And I think ideally modelers would like to think about all the aspects of control. We'd love to think about health, well-being, the whole sort of consortium of ideas, but sometimes this isn't feasible. I mean, we were very much told that our job was public health. Don't think of anything else. And then finally, I'd say teamwork. I've learned from this, it's been absolutely vital. So in the UK, we've been really lucky to have this group called SPIMO, which has integrated all the projections together from multiple different groups, which means there's a shared responsibility. So, you know, it's not, if something goes wrong with my model 1 week, it's not the end of the world. There's lots of other groups that are also putting in things. So we've got this sort of, this safety net. And I've also been lucky enough to be part of this Juniper consortium and this large supportive team in Warwick. So I'm going to just put this up and I'll go through it in 1 minute, I promise. So what are the lessons for this whole OMNI-RÉUNIS consortium? I think be prepared is the best I can come out with. So multiple models of multiple infections are always useful, especially if they're modular and we can sort of bolt things together. So, you know, we wouldn't have thought the next thing was going to be monkeypox, but fortunately we've got people who've got STI infection models and we've also got smallpox models, and we can sort of shove them together and do an early mashup. Statistical inference is hugely important throughout everything, and sort of having good statistical inference in place is useful. Maintain really good connections with data providers. As I said, data's key. Despite all we've done in COVID, we're still having trouble getting hold of the monkeypox data. Maintain good connections with policy advisors. Doesn't matter how good your model is, if people aren't going to use it, listen to you and take action, then it's just an academic exercise. And then finally, I think as a challenge for all of us, I think we ought to start thinking of a sort of a handbook of early action. So what are the key things you ought to measure in the first week of an outbreak to decide what type of intervention measures might be needed? When do you want to think about closing schools, pubs, restaurants, or borders? Thank you. Any questions?
Thank you for a very exciting presentation, Dr. Keeling. If you want to show your appreciation under reaction, there's a clap that we can use. There's so many of us. Yeah, that gave us a lot to think about. We have some time for questions. And so there's sort of 2 ways you can do it. If you feel comfortable typing it in the chat, I can read them out. And also, if you want to ask them in person, under reactions, you can put up your hand, and then we can turn on your microphone. So, okay, so Dean Carlin has a question. Like the UK, all US states saw the Omicron growth rate drop dramatically near the end of 2021, despite the lack of any coordinated imposition of NPI or statements from government leaders. The growth did not return until BA2 variant. And the question is, are you convinced that NPI is the cause of the dramatic drop in the BA1 growth rate? Or is there something else going on there?
Okay, my feeling is I don't think there is. I mean, well, I can certainly say from the UK perspective, it did seem to be the amount of testing that we did. Testing absolutely went through the roof in those weeks before Christmas, and we could see a very clear correlation between the amount of testing that was done by everybody and the sort of the drop in BA1. You can also see it in, I mean, I haven't shown this, but one of the things we estimate is sort of what's I call it precautionary behavior, but it's, how's the population reacting? And that actually correlates incredibly well with some of the Google Move mobility levels. And actually that also shows the same sort of thing. So it does look as if there was just a lot less mixing over that Christmas period, which did lead to that drop. Otherwise, we're in a really weird situation. I can't think what else could really dominate. We're also in a situation where there weren't that many people probably that could have caught BA1, given the amount of protection that was already in the population from past infection and vaccination. So yeah, it could have been a small wave, but it did really look as if, certainly in the UK, we slammed the brakes on of something that was going up exponentially, and then it just turned over incredibly sharply as people changed their behavior.
Thank you. Pei Yuan, yeah, please ask your question. I think you can unmute yourself. Yeah.
Okay, thank you. I want to thank you very much for this fantastic talk, and it's very informative and show the capacity of mathematical modeling in supporting the policymaker and public health measures. So I'm Pei Yuan from a postdoc from the CCDM and NAMS and York University. So I just have a very quick question about the shadow area in the figure in the roadmap for relaxation. So I just noticed that the confidence interval is different in each figure in the data fitting part. So I just wondering if we're using different fitting parameter sets in the different scenarios, why we're not using the same fitting parameter set? So
okay. It's a good question. So what we do, and I've sort of skipped over, I mean, I could have given a whole lecture on the statistics behind this. So almost from day one, I've been running sort of statistical fits to the model. So there's a huge MC chain that goes on in the background. So the parameters are being refined on a weekly basis almost. So some of it is just learning what's happening, and a lot of it is learning how the population is reacting. So some of the parameters, such as, what's the impact of age, or, how much less transmissible is someone who's asymptomatic, those don't change much. Those are fairly constant and have remained so throughout the pandemic. But things like, what's the amount of interaction that's going on between people this week compared to last week? Well, that's changing all the time. And that's the thing that's changing the confidence intervals and changing the projections. And sometimes we're in a situation of, last week, no one was mixing, and this week everyone is. And so things become very, very uncertain, and we get much bigger confidence intervals. But if we've been in a situation where the type of mixing has carried on for a few weeks, we're much more confident in what we're seeing. And so the confidence intervals shrink. So confidence intervals were usually quite big before we did any of the big sort of questions, oh my God, Delta's coming, what do we do? And it's like, well, we don't know, there's not enough data. So confidence intervals are huge then. So yeah, it very much depends on what the situation is.
Yeah, I understand. Like after the fitting part, it will be like very uncertainty. But before the fitting, like we have the data, we learn from the data, we use MCMC. So
why is that?
Have different fitting results?
Yeah, I mean, I think one of the issues is, so I'm only showing there a fit to one piece of data, which is hospitalizations. We're also fitting to deaths, ICU, cases. So there's 4 other dimensions, and sometimes those will be out of phase or something will change. And, we've had it recently where hospital occupancy has been going up, but number of people going in has been going down. And we're just going, look, that doesn't fit with our rational model of how this should work. So sometimes there's things just pulling it in different directions.
Thank you. Thank you very much.
Also, the other thing I'd say is sometimes we learn different things about the vaccine as we've been going. So it's like, oh, we've now got more data on the vaccine. We can tell you that things are slightly different, and then you have to refit everything.
Thank you.
Thanks. Arne Ruckert.
Hi there. Thanks, Matt, for this really comprehensive overview. I'm wondering to what extent equity considerations are integrated in any of your models. And I'm raising this issue because we know that the pandemic had incredibly inequitable impacts, and that people with certain social determinants of health were more likely to be negatively impacted by the virus. And so one example is prioritization, vaccine prioritization, and the importance of integrating equity considerations in making decisions about vaccine prioritization. So I'm wondering in general, to what extent equity considerations are integrated in any of your models?
The simple answer is we didn't. It was something we looked at all the way through. I mean, we were hugely aware of this as a problem, but the UK's got quite strict rules. So vaccines are just done on a sort of per capita basis, really. So, and it's very, very high. I mean, we did have very long discussions about, could we sort of, focus towards the more, we know which regions are more deprived. It was felt that actually the amount of time it was going to take to try and do that was counterproductive. So, if we'd have said we're opening it up to over 70s in this region, we'd have just got such a backlash against other regions. And really, you much better try and roll it out across the whole country. So I agree, in an ideal world, we'd probably want to focus it a bit more. But I think the practicalities of doing it was, let's have this as simple as possible. So, you know, one of the things someone suggested early on was, you know, we know that men are generally, you know, have more severe impact from COVID than women. So should you sort of differentiate according to gender? And everyone just went, no, it's too complicated. We'll just go down the ages, roll it out as quickly as possible and get things into everyone's arm. You know, there were measures done sort of locally. So I know in regions that, you know, high deprivation, they thought there were going to be problems. The public health teams on the ground did more pushing of the vaccine to try and sort of increase the levels, but there wasn't anything coordinated at a national level.
And do you see that happening now? Because I do feel we're not even doing it now when we think about more longer term changes to modeling. Do you see that happening now?
To some extent. I mean, you know, it's we know about this, and but it doesn't generally get addressed at a national level. It's much more about a local understanding. And I think, you know, something coming down from the government saying we need to do more here and pointing at someone actually quite often has a backlash. And it tends to work much better coming from the local public health teams who really understand what's going on in a region, much better than I would sort of sitting there with a computer model.
Thanks. Helene.
Oui, merci. Thank you, Matt, for that great presentation. Just one question. You know, we've read a lot regarding possible differential efficacy of vaccine mix and match, as well as intervals between different doses. Was that something that you were able to also take into consideration, especially in the UK, where, you know, often AstraZeneca was given first, followed by Pfizer a long time after? So were you able to assess that at all?
So most of the vaccine parameters that go into our model come direct from Public Health England, who are now UKHSA. So we didn't do a lot of that data simply because we don't have the linkage. So it's very complicated to get individual data on, well, we've got individual level data on who gets vaccinated, but we can't link that directly to the hospital data because of confidentiality rules. So we can't do that. We did, however, have lots of discussions about the interval. Some of that comes from the idea of, you know, do you want to give everyone one dose as quickly as possible? You know, the UK, I think we stuck our neck out a little bit, and we went with some of the literature that was really showing that you could delay this beyond sort of 3 weeks, which was the sort of recommendation for Pfizer. In terms of mix and matching, there's some studies that are actually looking at that. There wasn't a lot of that went on. Most of it in the UK was, you know, you either had AstraZeneca, or you had Pfizer. It was only sort of in a few cases where people turned up and, you know, they hadn't got the vaccine that they expected that we saw that. Certainly when we're thinking of boosters, we know that heterologous boosters are very, very effective. So that does play in slightly, but it more comes in the what's the average impact of vaccines across the population that we're looking at. And, you know, we'd love to do this, but you suddenly realize that you just have too many extra dimensions to your model in terms of all the different components you could possibly think of with different vaccines, especially as we're now thinking of fourth ones. It's, you know, too many different combinations, unfortunately.
Thanks. There's a question from Fritjof Lucher in the chat, and I'll just read it out. For the past 3 months in Ontario, the incidence per 100,000 has been about twice as high for fully vaccinated and boosted individuals than for fully vaccinated but not boosted, and for non-fully vaccinated. Can you speculate on why this is, and have you seen it in your models?
No, I'm utterly shocked at that. That goes against everything I would have thought. I mean, there may be behavioural things in here. So I don't know what your levels are in Ontario for vaccination. I mean, in the UK, we're at impressively high levels. A lot of our people who haven't been vaccinated are for, you know, health reasons, sometimes that they can't have the vaccine. And therefore, these are individuals who shield more. So whether there's any sort of compensatory behaviour here, otherwise, or unless, I mean, the other thing is it could be that people who haven't been vaccinated have been infected, and we know that infection is a very, very good way of building up immunity. So it could be that it's now getting to people and vaccines waning, whereas infection doesn't wane as quickly. So it could be that as well. I mean, I can probably push my model to do something like that, but it's not. I'm surprised that it's that strong an effect, but I'd be interesting to have a look at your data.
Great, thanks. I guess we have time for one more question. What I'm hoping is we've got one hand that's up, and then there's 2 or 3 in the chat. And so, Matt, if you're willing to stay after and chat, that would be wonderful.
Yeah.
And so that being the case, I'd like to invite David Earn to ask a question.
Great, thanks for a great talk, Matt, and nice to see you.
Oh, yeah, nice to see you again.
I was curious because you've got this model with thousands of ODEs, and you're interacting with other groups who are also building models. Do different groups have different types of models? I mean, are there people making agent-based models, purely statistical models, and others doing ODEs? And how does it work when you have these discussions? And has that been really valuable or confusing? I'm just curious because we run into these same issues.
I think it depends what we're doing and what the aim is. So if there's a sort of there's a hierarchy of different things that have been going on within SPI-AM. So the simplest one is a sort of nowcast, what's happening now, what's been for the last week or so. That there's a huge different number of models that go in. So there's some very statistical things. So there's people in my group who are doing sort of Gaussian process models to try and look at growth rates in different areas. That feeds in. There's people who've got other sorts of statistical models that just go in sort of, the classics of EPI-STIM type frameworks. There's people who do very simple non-age structured models that are feeding into that. And then there's people who do big, large scale individual based simulations that also come in. As we move through to sort of then doing predictions over 3 or 4 weeks moving forwards, the amount of models that feed into that reduces, and there's less of the statistics and there's more of the models that you've got a little bit more confidence in. And then as you move into the roadmap models, which are sort of the things I talked about at the end, where you're predicting 4 or 5 months in advance, there was only really 3 or 4 groups that were involved. Those sort of were all sort of compartmental models, age structured, regional. Some were stochastic, some were ODE, just purely ODE based, but I don't think we've got anything sort of individual based or anything very simple in there. It was almost finding the sweet spot where you can still infer the parameters and still have a reasonable idea of what might happen going forwards.
Okay, thanks.
Thanks, Matt. Your talk has generated a lot of interest, and I see there's a lot of questions still, but I am looking at the clock, and I'm kind of told. For a bit. So what I'll do is I'll just close, and then for those who want to stay on a little bit and chat further, let's do that. So so thank you to all for attending the webinar. Keep your eye out for future lectures in 2022, and we hope that you'll continue to join us. Perhaps if we can click on the right reaction, we can show our appreciation once more for just a really exciting lecture and discussion to Matt Keeling.
Thank you all. It's been nice talking to you.
Thanks, Matt.
Thank you. And then please stay on for a few minutes if we have time here, and it's okay with you, Matt.
Yeah.
Okay. Great. So yeah, Dean, please ask your question.
Oh, thanks. Thanks again, Matt, for the great talk. I was wondering if you could say anything about this term that was referred to as decoupling in the Delta wave, at least. Our provincial public health officers referred to the early data from from the UK as showing evidence for this decoupling of hospitalizations. That is, the ratio of hospitalizations to cases no longer was near a constant. But we didn't see this happen in either the US or Canada. And I was wondering if there's any understanding of this, or were you aware of that discussion back in July of 2021?
Okay, so we certainly saw in the UK that there was a reduction in the rate of hospitalizations per case. This could be because we've got more testing going on. So there is, you know, one of the sort of the complications with all of this is, you know, the gold standard of how many cases we've got is dependent on how much testing goes in, and that has been changing throughout the outbreak. So I think we did sort of, I hate the term uncouple because I don't think it really describes it. There was a change in the ratio between cases and hospitalizations. There was a more dramatic change in the ratio between hospitals and deaths. And I think that's basically because we had lots and lots of new treatments that came in over the summer of 2021 that really acted to suppress a lot of the deaths that we've been seeing previously. We'd also got very good vaccine uptake. So there was lots of things that were happening simultaneously. You know, given that this is a vaccine that protects slightly more against mortality and hospitalizations as it does infection, and given we were doing more testing, I'm not surprised. So I don't think it's as simple as, oh, it's the Delta wave that's doing this. I think it was a mixture of things within the UK and possibly a little bit of Delta. I mean, I think my parameters for Delta, there's slightly less hospitalizations, but we're talking 20% less, not a huge reduction.
Right.
Not like we saw with Omicron, where we know Omicron is not quite as severe.
Right. It was certainly confusing at the time, and it did drive policy in Canada, this UK data, and unfortunately, it was the wrong policy.
Yeah, I do think it's very interesting how quickly a term like this, oh, it's decoupled, or oh, this works, or oh, that doesn't work. You know, I mean, we've got a mantra in the UK that these short-term breaks don't work. They don't reduce cases, they don't reduce hospitalizations. And you go, look at the graph. But it just gets said so much that people sort of feed into that. And I think we've got to be very careful of these, you know, very quick, banal comments of, you know, I mean, it's like Omicron is mild. Now, it's not mild, it's just not as severe for some people. But if you've got a massive outbreak, you're still going to have lots and lots of hospitalizations. So, yeah, I think we just need to be careful.
Thanks. Maybe we'll make this our last question. It's from Amy Herford. She starts with awesome talk. And she said, do you mention a clear plan for closing? Is a clear plan for opening after closure also necessary? There's a few questions. Was the high compliance with Chris Whitty's request because the endpoint was clear? Christmas. Circuit breakers have a defined endpoint. Does that help with compliance? And so she wonders whether we're missing compliance components of measures with defined endpoints in our models.
I think so. I think, yeah, great set of questions there. I think a clear plan for reopening is always a good idea. Sometimes you can't do it, you know, the situation very often is you go in, you know, you hit it hard and fast, and that's always the rule with these epidemics. So it's easier to put the control measures in than it is to take them out. But I think thinking of ways of doing that sort of, you know, to buy you time is a good thing. I think the question about endpoints is really useful. I think psychologically, if you know you've got, you know, if someone says to you, you can't do something for 2 weeks, you go, okay, I can manage with 2 weeks. You know, I know where I am in that situation. And I think that's very strong. I mean, it's noticeable that the more contained lockdowns that we did in November, and also the ones in January, where we sort of knew there was an end in sight, were had much less impact on the economy. And I think that's because people weren't in this panic, oh my God, I'm just going to stop in and not do anything. We learned what this meant. So I think we were much clearer. I think Chris Whitty, I mean, you guys won't know him, but you know, he's like he's a sort of TV hero almost in the UK. He's got this not quite cult status, but it's getting there. And so I think if he comes on the telly and goes, you need to do this to save your family,